Welcome, I'm Janak Goyal, and in this section I will review some sonographically guided procedures of ankle and foot. Let's review the attachments of joint capsule before we proceed for injection. The fibrous capsule of the ankle joint is attached proximally to the tibial and malleolar articular processes and distally to the talus near the margins of trochlea, except in front where it is attached to the dorsum of the neck of talus. For the injection of the ankle joint, patient is seated with the knee flexed to 45 degrees and foot resting on the examination table. Ankle joint can be injected either from distal to proximal or proximal to distal, medial to lateral or lateral to medial approach. The choice of approach is based on the individual preference and presenting pathology. Here I have shown you an injection from distal to proximal approach. It's from distal to proximal approach, and here is the animation and the distended recess of the joint capsule being approached from distal to proximal. Alternatively, you could do from proximal to distal, medial to lateral, or lateral to medial. For the injection of retrocalcaneal bursa, the patient is placed prone with the foot hanging out of the table. I prefer an out-of-plane approach for injection of retrocalcaneal bursa. The transducer is placed along the long axis of the Achilles tendon, and the retrocalcaneal bursa is identified deep to the Achilles tendon between the tendon and the calcaneus. The needle is directed in the bursa from medial to lateral or from lateral to medial, and will be seen as an echogenic dot entering the bursa. I have seen a lot of confusion about the anatomy and the definition of subtalar joint, even in some good reference textbooks. Let's review the anatomy and anatomically accepted nomenclature of subtalar joint. There are two separate articulations between the talus and the calcaneus. The posterior articulation forms the subtalar joint proper between the posterior facet of the calcaneus and the posterior part of inferior surface of talus. The anterior articulation, known as talocalcaneo-navicular joint, forms a single joint cavity between the head of the talus, navicular bone, superior surface of spring ligament, middle and anterior facet of calcaneus, and middle and anterior facet of talus. Now you look at it, this is your subtalar joint situated properly between the posterior facet of the calcaneus and the posterior part of inferior surface of talus, and here is the whole joint called talocalcaneo-navicular joint, which is often called as anterior subtalar joint in some of the textbooks, and causing some confusion. So this is not an anterior subtalar joint. This is a talocalcaneo-navicular joint. To obtain a good sonographic view of the posterior subtalar joint, one end of the transducer is placed just below the lateral malleolus with the foot in slight dorsiflexion, and the other end directed posteriorly towards the heel over the posterior subtalar joint. If you look into this picture, here is the placement of the transducer just below the lateral malleolus, and in this image the transducer should be placed just here, just below the lateral malleolus, crossing over the posterior subtalar joint and the fibularis tendon towards the heel. Now in this image what you're looking at, the sonogram shows the posterior subtalar joint, and you're seeing the fibularis brevis and the fibularis longus tendon, and here is your lateral aspect of the calcaneus, and here is your talus. For posterior subtalar joint injection, patient is either seated or supine with the slight inversion and dorsiflexion of the foot. The one end of the transducer is placed just below the lateral malleolus and the other end directed posteriorly over the subtalar joint, just like this. Here in this video clip, you're seeing the subtalar joint being injected from anterior to posterior approach. Here is your needle getting into the subtalar joint. Here is your fibularis brevis and fibularis longus tendon on the calcaneus. Here is the tip of the talus which you're looking at, and here is your animation showing you the needle going into the subtalar joint, right crossing over the talus into the subtalar joint, and here is the fibularis tendon and the calcaneus. Let's review the attachments of MTP joint capsule before proceeding for the injection. The fibrous capsule is attached to the articular margins. Here is the fibrous capsule attached to the articular margins. And the synovial recess extends beyond the metatarsal head. And here is your synovial recess extending beyond the metatarsal head. The thick, dense plantar ligament is firmly attached to the base of phalanx and attached loosely to the metatarsal. For the MTP joint injection, the patient is seated with the knee flexed to 45 degrees and the foot resting on the examination table. Under sonographic guide, my target for the injection is the synovial recess proximal to the metatarsal head, and there are multiple approaches to the MTP joint injection as shown in this image. The joint can be injected in plane or with an out of plane technique from medial to lateral, or from distal to proximal or proximal to distal approaches. Here in these images, I'm showing you a distal to proximal approach for the injection of the MTP joint. Here is your needle and the syringe getting from distal to proximal into the synovial recess of the MTP joint. Here's a video clip showing the synovial recess being injected from distal to proximal. The ultrasound guided injection is accurate and less painful as compared to the palpation guided method of injection of MTP joint. Plantar fascia injection can be performed from anterior or posterior or a medial approach. I prefer in-plane long axis approach from distal to proximal with the patient in a supine position and foot placed at the edge of the examination table. I inject both superficial and the deep attachment of the fascia at the calcaneus and normally make multiple needle passes in the fascia after the injection. Here is the positioning of the patient and placement of the transducer. Here is the long axis approach which I usually use for injection. Here you could use the short axis approach, and alternatively you could also use an approach from the proximal to distal and the coming from the posterior aspect of the heel.